And here we go. Welcome everybody to The Big Idea. I'm Dr. Jeffrey Hanna, and I've got one for you today on mild traumatic brain injury, eye, and also balance function. I've really been looking forward to sharing this particular brand new bit of research that's come out here. And I'm going to be a little bit more technical with this one here, but super important for anybody who's had a head injury, who's had some kind of a whiplash injury, because two of the most common things that people will describe after that is that my vision gets super blurry and I feel like I am off balance. The point here that I'm going to be illustrating for you here is that yes, you're going to need rehabilitation for the brain. You're going to need it probably for the eyes and also for the balance system, but the neck is also a major player in this. So I'm going to be diving into a little bit of the research here, maybe a little bit more than I do in some of the other videos, but just to illustrate some of the findings, both what can improve, what we need to do additional therapies for, but also as a way of corroborating some of the bits and pieces that I say on my other videos so that you guys know I'm not just making this stuff up on the fly here. I'm also going to add in the end a little bit of a commentary in terms of how the particular brand of care that we do in our practice is different, but it's ultimately working to help to achieve those same kinds of things. So hang in there for this one. This is going to be a good one. Okay, now before we jump into the research, I just want to give you a bit of a broad appreciation for the system that we are dealing with. What I've got here for you are a couple of illustrations that show the different pathways that are in the brain. And these are showing pathways as if they are going to be on one side, but these actually overlap and these are on both sides. So the first one that I've got here on the left, fancy term, medial longitudinal fasciculus. Don't worry about the name. In brief, it is a major relay system to make sure that eye, head, and inner ear movements are going to be properly coordinated. Very basic. If you are looking side to side like this, in order to maintain gaze stability, it's important that your individual eyes are moving and able to focus at the exact same pace. This system receives a huge amount of input from this other one here that we have on the right. This is going to be a combination of inputs that are going to be coming from the inner ear organs, which are responsible for balance and equilibrium in both static positions, but also as you're moving your head and moving your body like this. It's also going to be a huge amount of input coming from the cerebellum. It's a lobe of the brain that's at the back of the skull right here. It's one of the most commonly injured areas in head and whiplash injuries, and it is the major conductor for all kinds of processes that go on inside of the brain that deal with fine motor coordination, including the eyes, so it feeds into this other system here. But what it also does is it's a relay for so much information that actually goes up in the higher centers of the brain, including number one, the prefrontal cortex, which is going to be responsible for our mood, for our ability to do complex thinking, for logic, for emotional regulation, all kinds of things like that. And also it's a major source of input for what's known as the parietal lobe. This is the one that lets your brain know where your body is in open space. And the cerebellum, also as I've illustrated right here, receives a huge amount of input from nerve receptors that are everywhere in the body, but a huge number of them are coming from the joints of the upper neck, because it's very important, again, that our brain knows where our head and our body is in open space. So very, very intricate neurological pathways. There's a lot of stuff that's going on here. Brain uses a huge amount of bandwidth to process this kind of information. And so then you can appreciate that if there would ever be a disruption to this system, whether it's going to be from the eyes, whether it's going to be from the inner ear, whether it's from the cerebellum, or whether it's from the neck, that one of the major consequences that a person can start to experience is blurriness in their vision and also a sense of disequilibrium or sense where their balance is off. Even if the world is not spinning around like vertigo, it feels like a person's kind of on a perpetual rocky boat, always bumping into things, stuff like that. So that's just a bit of appreciation for what we're dealing with. Now let's jump into the research. Alrighty, cervical spine vibration modifies oculomotor function in young adults with traumatic brain injury. The lead author right here, Dr. Alice Cade. I had the good fortune to meet her in person in New Zealand some many years ago. She's awesome. So I was reading this article just for the content first. It's like, wow, this is awesome. And then I saw who the author was, and I had to reach out to her saying, okay, I really appreciate this. So I will do my very best to translate all her findings into English, and she reserves the right to correct me if I make any honest error here. So I'm going to be reading a little bit more than I usually do, but this hits on so many important things. The purpose of this study was to investigate if vibrational interference of spinal proprioception affects oculomotor function, visual attention, and processing and selective attention in individuals with mild traumatic brain injury. Translating a couple terms there. So vibrational interference. What they did in this particular study, simply put, was they would use a little electrode that would offer and produce like a small amount of vibration through the neck, the idea being that it's sending more coordinated kinds of information up to the brain. There was no intervention, there was no chiropractic adjustment, there was no stretching or anything done here. They just simply wanted to see, does input in the neck have an impact in terms of how this oculomotor eye system is going to be working. And spinal proprioception, that's the fancy term for those kinds of nerve receptors. We have different kinds of nerve receptors in the neck. We've got some that are responsible for pain. We've got others that are responsible for physical pressure that you can detect movement. And then you have this group, which is actually the most abundant by far, the proprioceptors, giving that information to the cerebellum, to the inner ear, to the eyes, again, so that your brain knows where everything is in open space. So each subject completed a battery of computer eye tracking assessments, including egocentric localization, functional stability, smooth pursuit, saccade, Stroop, and a vestibular ocular reflex. Don't worry, I will explain what those are in just a moment. And then had their cervical spine function, a flexion relaxation ratio, recorded at baseline. In other words, they're testing a number of different parameters to see how well the eyes and that balance system is working. And they also were checking to see what the resting muscle activation was in the neck to see if there was actually a difference between people who did have some kind of a head neck injury versus people who didn't. And then what they did was they applied a spinal vibration, 100 hertz, to the cervical spine, and then they redid the test to see if having that additional input made any difference at all. Following cervical vibration, significant pre to post differences were seen in both the mild traumatic brain injury and control group for egocentric localization, fixation stability, pursuit, saccade, Stroops, and visualo-ocular reflex. So the conclusion, cervical spine vibration improved cognitive, so it affected not just the balance centers, but it affected how the brain itself worked, and also ocular performance in the mild traumatic brain injury group with a vestibulo-ocular reflex, Stroop, and pursuits, but it had some mixed findings in the control group. I'll explain what those are. Here's the important thing. These findings suggest that some, not all, but some optometric eye things with mild traumatic brain injury symptoms may result from spinal or proprioceptive dysfunction, as altering input appears to positively impact visual outcomes. In other words, the neck and getting treatment for the neck can have an impact on improving the eye, the balance, and the upper part of the brain function. So that's kind of a big deal and very important, again, for people if they've ever had these they've had these whiplash kind of injuries. You've got to focus on rehabilitating the brain, the eyes, the inner ear, yes, but you also got to look at the neck because it's providing huge amount of input so that all this stuff can work as good as it possibly can. So let's have a look, and I'll go through a few of the other bits in this particular study here. So recent research has suggested that some visual mild traumatic brain injury symptoms may have cervical spine dysfunction as a contributing factor rather than brain injury alone. It is impossible to injure your head without also injuring the neck. Supporting this dual site of injury idea, those with mild traumatic brain injury have a higher incidence of neck pain following the head injury as a mechanism of injury. In mild traumatic brain injury may also cause concurrent cervical spine injury. Literally what I just said, you can't have a head injury without also having a neck injury. So altering sensory or afferent sensory input, so information going to the brain, with whole body vibration has been shown to improve cognitive performance in a range of conditions. This is actually important, not just for brain injury, but a lot of other things. So let's have a look at some of those. Alzheimer's, Parkinson's, stroke, and also improves performance on what's called a Stroop test in young adults. This has to do with your ability to regulate different brain functions like an override mechanism. Again, I'll show you what that is in just a little bit here. So they are talking about then that along with muscle spindle information, especially from the neck, afferent information from vestibular, inner ear, and visual signals also combine to create the brain's internal map of where the body is and what it is doing. This supports what I've said on a lot of other videos, that it's not just the neck, it's not just the inner ear, it's not just the eyes, it's the combination of all of them that's sending the input to your brain to know where and how everything is and how things are supposed to work. So if there is a mismatch or conflict between multisensory input, then vestibular input is emphasized and proprioceptive input weighting is minimized. What this means is that if there is ever a mismatch between signals among these different signals, your brain says, okay, we got to think, well, what's one going to be top priority? That's going to have to be the inner ear. Problem there is if that has ever been disrupted or injured in some way, that then is what can cause a person to start feeling this sense of sway, and it has all of these downstream effects in terms of posture, in terms of muscle tension, in terms of course, how they feel, but also in terms of eye function. So by measuring vestibular function, you can look then and use that as a proxy for what's going on in other kind of systems. But anyway, let's go through here a little bit. What were the tests that they did for these individuals? And I'll try to do this on one little summary right here. And by the way, if this is a little bit more technical than you want, feel free to fast forward toward the end of this video, again, where I'm going to give you a little bit of the take-home kind of message. But I know a lot of people who deal with these kinds of things, they want to appreciate some of the intricacies of the hardware that's involved and how is it that this actually works. If you're that kind of person, this part of the video is for you. Otherwise, don't worry, skip ahead. So what they did was they did 6 different tests using a computer to measure eye function. Number 1, egocentric localization. They would say, here's a dot on the screen, and we want you to line your body up to where you feel it is directly midline. So your ability, again, for your brain to be able to process where your body is relative to a fixed point. They also did a fixation stability task. Said, okay, simply put, stare at a dot on the screen like this. For many people, they can identify an object, but then when they have to focus on it for a period of time, if the eye muscles begin to fatigue, things start to get blurry. Very common for people who say, oh, my eyes get blurry and I start getting headaches after I've been looking at a screen all day. Or if I'm trying to read something, it's just really, really hard. So they checked that. They did what's called a smooth pursuit. So there was a moving object kind of on the screen going both up and down to see, are the eyes only going to be able to track where that object is going? Oftentimes when people have had the head or the neck injury, there's going to be slight lags or slight mismatches in both a vertical orientation, also in a horizontal orientation. The more that that is off, the harder it is to do, the more strain there is on the eyes, the inner ear, and you can use that as a really good metric to see pre-treatment, whatever it is, post-treatment, is there an improvement in brain function? They also did what's called a saccade and an anti-saccade test. Uses a slightly different part of the brain, but in brief, there's going to be a dot that appears on the screen over here, and you just have to look at it as fast as you can. Then it moves. Look here. Look here. So are the eyes able to do these quick movements that's going to be involved with reflex activation? And what they also did is what's called an anti-saccade test. So that is, you see it, but then look literally the exact opposite way from where that stimulus is. This is not just testing the eyes themselves or the pathways that are involved with those fast eye movements, but also your prefrontal cortex and your ability to then make a different decision. So you have an input, but can you override that input and literally do the exact opposite? They also did that with what's called a Stroop test. So what you would see here is you would see an object, or 4 different quadrants of colors right here, and then there would be a word or a color, but you see that that word is not actually red. It's actually, the color of that word is blue. So what you need to do is to override the idea that it's red. You can see the color blue, and you want your eyes to go then as quick as you can to that particular color. So again, this is not testing eye function. This is testing more the upper centers of the brain. People, if they are not able to override and to actually do that, what seems to be a relatively simple, but actually involves a bit of a complex overlay test, that's a sign of injury to the upper part of the brain. It's also a really good screening test that you can do for people if they are experiencing any number of neurodegenerative conditions. So Alzheimer's, Parkinson's, different kinds of things like that. The last one they did was a vestibular ocular reflex test. So that was where you've got a fixed object on the screen, but then what you're doing is you keep your eyes focused on it, and you are just simply moving your head side to side or up and down like this. Can you maintain gaze stability with those particular kinds of movements? So they did a lot of different tests here. What they then did was they put a couple of little electrodes on the person's neck at the level of the C3. Well, they put the electrodes to extensor muscles at the level of C4 down through C7, so that this way they could measure what the resting muscle tone was, and they wanted to see, was there a difference between people who had traumatic brain injury versus people who didn't. And then what they did was they applied a electrical vibratory stimulus on the right side of the neck at the level of C3, C4 on a particular muscle called the splenius capitis muscle. This is one that's going to go from the neck and it's going to go up to the head kind of like this, and it's involved with side bending and also with extension like this. Now, what I'm going to do is I will skip ahead here to what their final conclusions were, because I know this is a bit of a mouthful already at this point. So firstly, what did they find? They found that there was a difference between the flexion relaxation ratio, in other words, muscle activity, in the mild traumatic and control groups at baseline, with the mild traumatic brain injury group having a lower flexion relaxation ratio than the control group. In other words, the muscles were more active. The muscles were tighter. The muscles were stiffer. Again, in people who had a head injury. You can't disconnect head injury from neck injury. The neck was involved and having some kind of a role here. So what they found, their key findings, the main aim of the study was to establish if vibration applied to the cervical spine. So again, it's not a full-blown treatment per se, but it's looking to see that is the neck having an impact in terms of eye and brain function in the first place, was to establish if vibration applied to the cervical spine affected computerized eye assessments in participants with mild traumatic brain injury. Overall, vibration tended to improve performance in the mild traumatic brain injury group for the vestibulo-ocular reflex, so it was easier to move the head and to maintain gaze stability. There was an improvement in the Stroop test. In other words, the frontal cortex was able to coordinate information better, and pursuits. So your ability to follow a moving object like this. It had mixed effects on the control group, improving vertical areas but worsening anti-saccade and Stroop performance. Interesting, the people who were normal, that their ability to go up and down like this, and also the ability to use the prefrontal cortex, there was actually a bit of a distraction. The normal people got a little bit worse. They talk a little bit later in the article that what they think could have been going on is that in healthy people, the vibration is kind of like a source of irritation. It's a distraction. And as a result, the brain's not quite able to communicate and work the exact same kind of way. But for people, when they did have some kind of a head or a neck injury, that distraction actually allowed the brain to work better overall. We also found those that mild traumatic brain injury have poorer flexion relaxation ratio than healthy controls. That's what we said, which suggests a greater amount of cervical spine dysfunction. These findings support the idea that vision-based mild traumatic brain injury symptoms involve some abnormal spinal or proprioceptive input potentially caused by the same injury that caused the mild traumatic brain injury. And this goes back to so many things I talk about on this channel. And that is that when you're dealing with symptoms that involve the brain, the eyes, the inner ear, yes, these are all important. We need to work with neuro-optometrists and vestibular physical therapists and concussion specialists, but we also can't ignore what's going on in the neck. It may not solve 100%, they didn't find that in this research, but it is a piece of solving the puzzle so that people can get as much of their brain, their body, their eye, their inner ear function back as close as possible to 100% to the way that it was pre-injury. Now, I'm going to do a little bit of a commentary here in terms of how what they were doing and what they were looking at in the research is ever so slightly different from what we typically work on in clinical practice. And it has to do with the nature of that proprioception, that body, that neck to brain input about where things is. The muscle that they were targeting, and I'll rewind here a little bit, there's actually 4 layers of muscles along the back of the neck. You cannot isolate the deeper muscles, and that's what I have illustrated in this picture right here. All of the very small muscles that go along the back of the neck, the ones that are most commonly injured in a head or a neck injury, you can't isolate these. These are actually the ones that have the most amount of proprioceptive information that goes up to the brain, second to none. They were only able to isolate a couple of the muscles that were in the more superficial layers of the neck, because that's the only area that you can apply vibrational stimulus. In addition to that, vibrational stimulus, this is good, but it's only going to be applying that additional information in the moment when the vibration is applied. So what my point there simply is if we're wanting to make more longer term connections, it's important that we're actually working on these guys right here. The question then is, how do you actually isolate the muscles that are involved most accurately with proprioceptive information? One piece of that is physical therapy. You have got to work on strengthening and improving the stability of the muscles that are in your neck. I talk about this in a few other videos on the channel, that one of the challenges with this is that if we try to do big movements like this, I just need to flex my neck up and down. Well, what happens then is the big guys keep getting bigger and the small guys keep getting smaller. So it doesn't really isolate those muscles. Unfortunately, it's the stupid, simple, subtle movements that make the biggest difference. What does that involve? That involves, simply put, tucking your chin in like this, making sure that whether you are standing, sitting, or sleeping, you keep your ear over the tip of your shoulder like this. And if you want to make that more effective, what you want to do is you want to put your tongue against the upper part of your palate, not just the tip of your tongue, but the whole tongue. So imagine, if you would, that you have a straw, put the straw under your tongue and suck upward. That will elevate your tongue against the roof of your mouth so that as you are doing these kinds of exercises, only a few minutes a day, ideally to be 100% of the time, especially if we're focusing, working on computers or our phones or whatnot like that, that you're keeping your ear over the tip of your shoulder. That's what's going to allow these muscles to activate and start to rehabilitate themselves the best kind of way. I know it seems very silly, very simple, but those are the best ones that we have so far for rehabilitating the neck. But the other parts then is making sure that these joints that these muscles attach to in the neck are moving the right way. Because if in that injury, whether the head injury, the neck injury, whatever it was, the joints are designed to move. If, though, the injury damages some of the ligaments on the inside, even if there's no bleeding, broken bones, or even bruising, if there's damage on the inside, that means that those joints are no longer able to move the way that they are supposed to. They're either moving way too much or they're moving too little. That then is going to cause the muscles to go into lockdown mode and as a result be sending the wrong kinds of signal up to the brain. This then, it's the upper cervical chiropractic side of the equation. Not where we're doing gross manipulations or anything like that, but very precise, very gentle corrections to restore that normal movement so that these muscles are able to relax, so that they're able to send your brain not just a temporary stimulus that says, okay, yeah, that feels better, that functions better, but to where that's actually going to be sustained, to where the brain is getting as close as possible to 100% of the right information so that it's not having this sensory mismatch. So very important, again, person's ever had that head neck injury, you've got to make sure you've got a proper assessment of the neck. You need to make sure that things are moving the right way. You want to make sure that things are healing, stabilizing, and you also want to make sure that you're doing the right kind of rehabilitation exercises for your neck so that it's going to be able to help with that overall brain balance function. So a lot of stuff packed into that particular video here. Again, a little bit more technical than I like doing. But again, I hope that you get some of the overarching principles here. In brief, lots of neural traffic that goes on and requires coordination from the upper centers of the brain, the back centers of the brain, the eyes, the inner ear, and also the neck. If there is ever a mismatch of that information, you need to identify what's the origin of it. And it's usually going to be more than one thing, but when you add them all together, that's where we're able to get the best kind of results. And anytime that there is a mild traumatic brain injury, it means there was a head injury, there was probably also a neck injury. Very important to make sure that you're also treating the neck side of the equation so that you can get the best results possible. So hope you guys did enjoy that particular video. If you did, please do make sure you like and subscribe to the channel here, and also share this video with friends, family, anybody who you believe would benefit from this particular kind of information here. And if you want more info, you can check out any other videos I have on this channel, or you can also go check out our clinic website, which is clearchirospokane.com, where we help people out with all these different kinds of conditions, serving the Pacific Northwest, Inland Northwest, and even the lower areas of BC, Canada, those areas there. So thank you guys for watching. This is Dr. Jeffrey Hanna at Clear Chiropractic. Get well, live well, stay well.